So I want you to imagine you are an intern, and a primary gravida at 36 weeks comes in with history of a sudden break on her waters. You examine her and you find out that there are no contractions. What do you do? I'd like you to type in the chat how you would want to manage this particular patient. What I'd like you to know is that knowing how to manage PROM can be the difference between a healthy delivery and a crisis. PROM accounts for 8 to 10% of all pregnancies, and it can lead to very serious complications if not managed well. Complications like infections, preterm labor, fetal distress, and many other things. In this particular video, at the end of this video, you will be able to accurately identify PROM using clinical skills and diagnostics tools. You will also be able to assess the risks and tailor the management based on the gestational age of the patient and the specific factors that your patient has. If that's what you would like to learn, I'd like you to stick around. At the end of the video, I will be able to share with you step by step on how you can manage a patient with PROM, so that given that scenario in real life, you'll be able to do something and you'll be able to save lives. So when it comes to premature rupture of membranes, which that's what PROM stands for, timely diagnosis, vigilant monitoring, and a tailor-made intervention is key. It's key for the safety of both the mother and the fetus. So for us to be able to understand premature rupture of membranes, there are certain things that we need to understand. Firstly, what are these membranes? Okay, so we know that once a woman is pregnant, the fetus is in a gestational sac. Okay, this gestational sac has a membrane around it, okay, which is called the amniotic membrane, and within the amniotic membrane you find amniotic fluid. And some of the roles of these membranes, amongst the many that are there, is that one, it's for the protection of the fetus. So there is a barrier between the internal environment of the uterus, where the fetus is, and the external environment. So therefore, it functions as a barrier to prevent infections from getting to the fetus. Another thing is that because there is fluid within the amniotic sac, it functions as a shock absorber. So whenever there is trauma to the abdomen of the woman who is pregnant, the fetus is not really injured. It's one of God's amazing designs, because if you think about it, even the brain is floating within a fluid, so you can't feel the weight of the brain, and also there's a certain level of protection which is around the brain because of the fluid. It's the same with the amniotic fluid. Another thing, it regulates the temperature for the baby. In as much as the mother would be cold or hot, there's going to be consistent internal environment for the fetus. Another thing, it keeps the baby's moisture, or the baby's skin moisturized. And also, remember, this baby is in the skin is fragile, the skin is being formed, so it's in a state where there is constant moisture around the skin of the baby. It also allows for movement, okay, because of the fluid within the amniotic sac. It allows for movement. So now, what is rupture of membranes? So rupture of membranes was simply saying there's a break in the continuity of the membrane itself. Okay, whether it's at term or it's before term, the membranes have ruptured. There's a break in the continuity. Therefore, there's an escape of amniotic fluid. Gestational age, okay, this is the age in weeks at which the pregnancy is at, or the fetus is at. Okay, it goes from 0 all the way up to week 40, okay, plus or minus 2 weeks. Another term that you need to understand is age of viability. So age of viability, this is the age at which the fetus can survive outside the uterus. Okay, this is the age at which the fetus can survive. So age of viability is the age at which the fetus can be able to survive outside the uterus. And term, this is 37 completed weeks. So this is 37 plus 7 days. This is the word, or this is the gestational age that we refer to as term. So now that we know all these things, what is premature rupture of membranes? So premature rupture of membranes, this is the spontaneous rupture of the membranes before the onset of labor. So there's a break in the continuity of the membranes before the onset of labor. So here in this context, maturity is if it occurs after labor has begun. Okay, we're going to refer to that as mature rupture of membranes, okay, which is spontaneous. But in this case, we're saying it's premature rupture of membranes. So these membranes, there's a break in the continuity of the membranes before the onset of labor. All right, and so this can be classified into different types based on the gestational age. So if PROM happens after 37 weeks, okay, so remember we're saying it's a spontaneous rupture of membranes before the onset of labor. So if it occurs after 37 weeks, we're referring to that as term PROM or PROM, okay. This is when it occurs after 37 weeks, okay. Then if it occurs before 37 weeks, we refer to it as preterm PROM or PPROM. This is when there's a spontaneous rupture of membranes before the onset of labor, before term or before 37 completed weeks. If the rupture of membranes has been there for more than 24 hours, it is referred to as prolonged rupture of membranes. Okay, it's referred to as prolonged rupture of membranes. Now, there are many different things that can function as risk factors for PROM, and we're going to look at them even as we look at the pathophysiology of PROM. So, what is the main problem? When we talk about pathophysiology, we're saying how does the pathology affect the physiology and lead to clinical features, okay? So now, what's the main problem in PROM? The main problem is that there's rupture of membranes before time. There's rupture of membranes before time. That's our issue, because when it occurs at the right time, remember the body has initiated labor. Okay, labor has started, which means the process that ensures that the fetus is going to be out of the uterus has already begun. So if the membranes rupture, labor is going to progress even more, and the fetus is going to come out. But if there is no labor, there are no contractions, but the membranes have ruptured, the fetus is still in the uterus. But then remember why the membranes were important in the first place. We said it functions as a barrier. It's protecting the fetus from infection. So if the fetus remains in the uterus, the membranes have ruptured. That means there's no protection anymore from the infections. The challenge that can be there is that we can have what is known as chorioamnionitis, and we're going to discuss that even more when we discuss the complications. So let's move to the left side. So you can see where it's written rupture of membranes. What are some of the things that can lead to the rupture of the membranes? What can lead to the rupture of membranes before time? So there are two factors that are implicated. One is if there's increased intrauterine pressure. Two, if there's a weakened membrane. If there's increased intrauterine pressure or if there's a weakened membrane. Okay, increase in intrauterine pressure or weakened membrane. So what are some of the risk factors? What are some of the things that can lead to an increased intrauterine pressure? One, if a patient has polyhydramnios, that means they have too much amniotic fluid. It means the pressure within the uterine is already high. That means any form of weakness in the membranes can lead to a rupture. Or there are more chances of a woman with polyhydramnios having premature rupture of membranes than a woman without polyhydramnios. Another one is multiple pregnancy. Okay, if there is more than one baby, more than one fetus, especially if they are monoamniotic, right? They are in one amniotic sac. again, it can lead to premature rupture of membranes. A woman with a big baby can also lead to premature rupture of membranes. Okay. Now, what are some of the things that can lead to a weakened membrane? One, infection. Okay. The presence of pro-inflammatory cytokines lead to, there's a reduction in the matrix which makes up the membranes. Okay, so the collagen is broken down, hence there's reduced strength in the membranes, which is going to lead to a weakened membrane. Also, based on research, there has been found a correlation between smoking and weakened membranes, which lead to premature rupture of membranes. Okay, so what would be our telltale sign that the membranes have ruptured? There's going to be a history of a gush of fluid, okay, from the vagina. There's going to be a history of a gush of fluid. Okay, it's not just trickling down, it's water breaking. So there's going to be a history of a gush of fluid, okay, and the patient will present with a history of having had a gush of fluid, whether at home or in their sleep or at any time. If the patient has overstayed at home and maybe an infection is setting in, the patient will additionally present with fever, tachycardia, a foul-smelling discharge. Okay, fever, tachycardia, and a foul-smelling discharge. Right? Now, if a patient presents, going back to the first statement that I made, you are in OPD or you're in maternity, a 36-week-old, a PG with 36-week pregnancy comes in with a history of a gush of fluid. What do you do? What are some of the questions that will occur in your mind the moment the patient comes with a gush of fluid? So the first thing that you want to do is you really want to confirm, is this PROM or it's something else? Okay, so now let's look at how you can accurately identify PROM using clinical tools and laboratory tests. So clinically, your patient is going to come with a history of vaginal discharge, which has a classical, it came out as it was a gush of fluid. It's described as a gush of fluid. It just happened suddenly and at one time. Your next question will then be, when did the rupture occur? Why? Because you want to calculate the time from the time that the rupture happened until now, when the patient has come. How much time has passed? It will be very important when it comes to management of PROM. Another question that you would want to find out is this really PROM? Some of your differentials can be one, it can be urine. Okay, maybe the patient has incontinence, especially if it's in the last trimester, because the weight of the baby is pressing on the bladder. So sometimes the woman can have, some form of incontinence. Okay, but then the difference is that the urine may be smelly. Okay, may have a different color. Also, it can be, the patient will tell you the fluid is coming out more when she coughs or when she laughs or whenever there's an increased intra-abdominal pressure. Then it can also be an infection. Maybe it's just a vaginal infection and there's a lot of discharge that the woman thinks is amniotic fluid. So what then do you do? If you have these thoughts and you want to confirm, is this PROM or is it not PROM? So immediately, something that you can do as bedside, you would want to do a speculum examination. And what you are checking for on the speculum examination, so that silver instrument that you can see there is a speculum. Okay, that's a Cusco's bivalve speculum. Okay, so you put it through the vagina and you get to expose the cervix and the posterior fornix. So you will find pooling. If there is really a PROM, you may find pooling in the posterior fornix of the vagina. So you'll find pooling in the posterior fornix. Usually you can see that the liqua you have to write down the color that you can see. Is it green? Is it clear? It's very important to note. Okay. Now, just because there is pooling, it doesn't mean you've confirmed that that is PROM. Just because there is no pooling doesn't also mean that there is no PROM. So you take it to the next level where you can use a nitrogen paper, okay, where we detect the pH. Okay, amniotic fluid has a pH of about 7.5. It's alkaline, and the vagina is acidic in nature because of the bacteria. So you will notice that if you get a nitrogen paper and you dip it, so a nitrogen paper is yellow, when you dip it in the fluid, it has to turn blue, which means it's alkaline. If it turns orange, then it's acidic, which means most likely there's an infection, and that discharge is just from within the vagina and it's not coming from the amniotic sac. Furthermore, you would like to aspirate. You get some of get a sample of the amniotic fluid, put it on a slide, and you send it for microscopy. So under a microscope, the amniotic fluid crystallizes. So there's a crystalline pattern known as a fern pattern. Okay, it looks like snowflakes. When you look at that picture in the top right corner, you can see it looks like snowflakes. So that is known as the ferning test, and that means the ferning test is positive, and you've confirmed that this is actually PROM. Now, another thing that you can do is you have to do an ultrasound scan. Once you do an ultrasound scan, you want to look at the amniotic fluid index. It will reduce, especially if the woman has been discharging this fluid or the amniotic fluid for a while. Okay, if they've been discharging the amniotic fluid for a while, you'll find that the amniotic fluid index would have reduced, and also it helps you just get to look at the physical profile of the baby and make sure that the baby is actually okay. Now, there are new ways of confirming. Okay, there are new ways of confirming by using biomarkers. Okay, one of the biomarkers that we use now is placental alpha microglobulin 1. Okay, so this is a protein abundant in amniotic fluid. Okay, this is a protein which is abundant in amniotic fluid and nearly absent in other bodily fluids. So that means if we get the sample and we test using what is known as an amnisure, okay, amnisure, which is a rapid test for placental alpha microglobulin 1. If it comes out positive, the sensitivity and specificity is about 95%. So if at the facility where you are, you have this amnisure rapid test, it would be important. It's very reliable. And another one is insulin-like growth factor binding protein 1. So again, this protein is synthesized by the decidua and found in high concentrations in amniotic fluid. And so you detect it in the vagina, secretions, okay? And so once you collect and you check, you'll be able to accurately diagnose that this is PROM. Okay, it's not coming from the vagina, it's not coming from any other place, it's coming from the amniotic fluid. So these are some of the new ways of investigating PROM. So now that we know how to confirm, how to diagnose PROM, how then do we manage a patient with PROM? How do we assess the risk and tailor management based on the gestational age and the patient's specific factors? So our management of PROM is going to be based on gestational age and severity. And here, when we're discussing severity, what we should keep in mind is how many hours from the time the patient started draining. Okay, so in the columns, we'll get to see the general things that we do with all the patients. If a patient is below the age of viability, If the patient is below 34 weeks but after the age of viability, if the patient is after 34 weeks, and if the patient is after 37 weeks. Let's get into it. So your patient comes to the hospital, they have been draining, but they've been draining for the last 5 hours. So it is less than 24 hours. What do you do? So you want to firstly, want to monitor the pulse. We're going to admit the patient, because we need to observe them for 24 hours if we're suspecting PROM. And remember, you've done your speculum examination, you have seen pooling, you've done your nitrogen test, it's come out positive, you've done your biomarkers, it's pointing towards PROM. So want to keep the patient, monitor for the pulse, monitor the temperature and the fetal heart rate. So pulse and temperature will help you know whether there's an infection setting in or not. And it will also give us the baselines for after 24 hours. If we measure pulse, temperature, and fetal heart rate, if there are derangements, we'll be able to know because we know how the patient presented at the beginning. And then want to give broad spectrum antibiotics such as amoxicillin or erythromycin, just to cover. Remember, the main challenge is that the membranes ruptured before time. So therefore, the chances of infection are higher in this setting. If the age of viability, if the pregnancy is below the age of viability, there's nothing much that we can do. And age of viability is different based on where you're practicing. In America, it's about 20 weeks. In the UK, it's 24 weeks. Where I am in Zambia, it's 28 weeks. In some of the countries like India, it's 28 weeks gestational age of viability. So we want to counsel the patient. And the spouse. And we do expectant management. So the challenge with the membranes rupturing is that it can trigger labor. So this is before the age of viability. The couple has to be counseled. We're doing expectant management. In the event that it progresses, most likely there's going to be a live abortion. There's going to be an expulsion of the products of conception, in this case the fetus. If it's above the age of viability but before 34 weeks, especially if it's after 28 weeks, we can want to give corticosteroids. There has been research which has been done which shows that because of the chances of preterm labor and prematurity, it's very important to give both antibiotics and corticosteroids. In this case, it increases the chances of survival. It reduces the chances of neonatal sepsis because of the antibiotics. It reduces the chances of asphyxia, because the lungs are forced to mature because you're giving either dexamethasone or betamethasone. And we want to make sure that the patient is resting, so bed rest. If it's after 34 weeks, in addition to everything else that we've done, we want to monitor for spontaneous labor. So remember, this is before 24 hours. So we put the patient on antibiotics, we're monitoring for any infection. And remember, we said that whenever there is a rupture of membranes, labor can be triggered. So we are waiting for spontaneous labor. It's the same. If it's again greater than 37 weeks before 24 hours, we monitor for spontaneous labor. What happens after 24 hours? We monitor again we monitor the pulse, the temperature, fetal heart rate. We want to make sure that there's no infection in the mother, and want to make sure that the fetus is okay. Part of the monitoring of the fetus, apart from the fetal heart rate, want to do a biophysical profile. Once we send the patient for a scan, want to do a biophysical profile and to make sure that the fetus is okay, there are no complications both to the fetus and to the mother. If it is before the age of viability, again, counsel the couple, expectant management. If it's above the age of viability before 34 weeks, we give DEXA, we give betamethasone. And remember, if favorable, and in this case, if there is, if favorable, we're saying if the fetal weight is okay, we're talking about the patient has received dexamethasone, and strictly want to prevent. We know that an infection can set in after 24 hours. We would want to induce labor. Okay, the weight is okay, the chances of survival for the baby are okay because we've already given DEXA. We want to induce, okay, in a favorable setting. If it's after 34 weeks, okay, after 34 weeks, and also remember, if it's before 34 weeks, we can still manage expectantly. As long as there's no infection, we can still manage expectantly and try to push them to 34 weeks. Okay, and try to push them to 34 weeks. So we keep the patient with close monitoring. Any derangement, we deliver, we induce labor. After 34 weeks, we want to do everything that I've already mentioned and induce labor if favorable. If not, then we cancel the patient for a C-section. Okay, we cancel the patient for a C-section. After 37 weeks, induce labor. If everything is favorable, okay, you do the Bishop score. If everything is favorable, then we induce labor. If not, C-section. Lastly, if there's chorioamnionitis or any of the other complications which can arise as a result of PROM, we want to firstly give intrapartum antibiotics, broad spectrum. Again, the amoxicillin, okay, or erythromycin. Okay, we want to give broad spectrum antibiotics intrapartum, and then want to expedite the delivery. Inform NICU, expedite delivery. Okay, in spite of the gestational age, because there's compromise to the mother. Okay, and if we allow the chorioamnionitis to continue, the patient may end up having sepsis. So once there's chorioamnionitis, we expedite delivery. Okay, but when there's established chorioamnionitis, avoid C-sections. Why? Because you end up introducing infection because you are going to be cutting, right? So you end up introducing infection in the mother's circulatory system. Okay, so want to expedite delivery and inform NICU. Yes. So what if you don't manage the patient properly? What are some of the complications? Or maybe you've managed the patient, but what are some of the complications that can set in if timely action is not taken? Okay, on the maternal side, we can have what we've already discussed, chorioamnionitis. This is where there's an infection, okay, there's an infection which involves the chorion and it involves the amniotic sac as well. So some of the manifestations of chorioamnionitis, one, there's going to be tachycardia, there's going to be an increased pulse rate, which is tachycardia. The patient also present with a tender abdomen. So if you try to palpate the abdomen, it's tender. There's a foul-smelling discharge. Okay, sometimes it looks greenish. Okay, and the plus or minus fetal compromise. Okay, usually there is fetal distress. Okay, so you look out for that, and we manage the patient. You have to do a septic screen. Okay, so you do a high vaginal swab. You want to do a urine culture. You also want to take the blood for FBC-DC, especially we are going to be looking at the white blood cells. We also want to do CRP, okay, the C-reactive protein, which becomes high if there is an infection. So we can do that and we manage our patient. Another complication of PROM is there's a higher chance of a patient undergoing a C-section who has PROM than a person who doesn't. So it's one of the complications. There's also PPH. Okay, if there's an infection, okay, there's a likelihood of uterine atony. Okay, there's a likelihood of uterine atony. So there are higher chances of the patient having PPH than in a patient without. Also, there is a higher chance of abruption placenta. This is where the placenta detaches before time because of the rupture of the membranes. Some of the fetal complications which are there, we have neonatal sepsis, Remember, the amniotic sac functions as the barrier which prevents infections, but if that barrier isn't there, then it's easy for vaginal microbes to ascend and cause infection. There's cord prolapse, okay, as the rupture is occurring, especially in malpresentation, the cord can prolapse. There's also higher chances of preterm labor. You notice when we're discussing the management, we were majorly talking about 34 weeks delivering the fetus. So there's preterm labor and there are higher chances of prematurity. And lastly, there's oligohydramnios. This lady is losing fluid. So if you do your index, you'll find that there is reduced amniotic fluid. So thank you so much for watching. Go and save lives. So for more content like this, feel free to subscribe and hit the bell notification so that you can keep updated whenever I send this wonderful content. Thank you. See you in the next video.